Good afternoon. Thank you for coming. Today we're privileged to have Dr. Jamie Daw here with us. She's a quantitative health services and policy researcher with expertise in quasi-experimental methods and the analysis of large surveys and administrative data sets. She studies how policies affect the barriers affected by reproductive age women and pregnant people in accessing health services, from gaining health insurance to connecting with providers and ultimately receiving high-quality care. Her current research agenda focuses on how Medicaid policy changes and new healthcare delivery models can promote improved healthcare access, quality, and health equity in the year after childbirth. Welcome, Dr. Dahl.
Thank you, Lauren, for that introduction. And thank you so much for having me. It's been a delight to be here in this beautiful fall weather on your beautiful campus. So refreshing respite from New York City. And I'm really excited to talk to you a little bit about some of the reforms that are going on in the Medicaid program to better support maternal health in the year after birth. And I've been told that generally there's only clarifying questions during the talk, and that we'll have a robust discussion afterwards. But if you have any questions, and you want to raise your hand when I'm speaking, please do. I welcome it, okay? All right, I just want to make a few acknowledgments. I'm going to be covering, many different studies from, that I've been working on for the past 5 to 10 years from various funders. We just want to acknowledge some of those off the bat. And just a roadmap for the talk today. First, I'm going to talk a little bit about what is this policy problem that we're trying to solve. So a little bit more about what's going on with maternal health in the US and health disparities in maternal health. And then I'm going to talk through this proposed policy solution. So thinking about how can we leverage Medicaid in that year after birth to improve maternal health. And I'm going to focus on 2 questions. Will this policy work to improve postpartum coverage? And will it work to improve postpartum health? We don't have the answers to both of these questions right now, but I'm going to try to peel back a little bit of the onion of what we do know now, and some of the areas that we think we should be focusing on as researchers, as policymakers, and practitioners in helping to support these extensions to be as effective as possible. So let's start with that first point, this policy problem. So the US has the highest maternal mortality rate among comparable high-income countries. Here, the US is in the lighter blue, and a set of other OECD countries in the navy. And as you can see, the US maternal mortality rate is double the next lowest performing country of Canada, and almost 4 times the rate in the other countries that are shown. And this mortality rate has not been improving, and actually quite the opposite. It has risen in recent years. So this is CDC data from 2018 to 2021. Each bar represents a year, and you can see the market increases that has happened even across just this 4-year period. So it seems like this is already an existing problem. It appears to be getting worse. And there are wide racial inequities in maternal health. So here it shows the total maternal mortality rate by year, and then non-Hispanic Black, non-Hispanic White, and Hispanic. And you can see that for non-Hispanic Black birthing people, the maternal mortality rate is 3 to 4 times that among white birthing people. Not shown here, but another population group at very high risk are Indigenous people as well, who also face similarly high rates relative to white birthing people. Putting this in context in the international comparison, we usually just think of, the total US maternal mortality rate, but I think it's really helpful to put the maternal mortality rate for Black birthing people on this plot just to show how stark and how poor the US is performing in delivering good maternal health to Black birthing people. And as you can see here in the orange, that is the maternal mortality rate among Black birthing people. That's 5 times now the rate in the next worst performing country of Canada, and 10 times the rate and the average of the countries shown. And you can see if you look just at the white maternal mortality rate, it's more similar to the average and more similar to the other countries shown. In terms of the geographic dispersion of high maternal mortality in the US, it's very much concentrated in the South. And this is relevant when we start thinking about Medicaid as a potential lever for improving this situation. You can see if you know much, I think, there's a lot of folks here that probably know a little bit about Medicaid, but this is mapping on, to Medicaid non-expansion states. But you can see, for example, in Tennessee, which has the highest rate, according to this data from the CDC in 2018 to 2022, it's about 41, which is, really, really high, especially compared to other countries. Illinois, just pointing out here as another example of 18, which is pretty close to the national average. So, why this is a national problem, but there's a huge geographic variation in these rates across states. And one key thing about thinking about maternal mortality is that the vast, vast majority of these deaths are preventable. So in recent years, states have established what are called maternal mortality review committees that carefully go through each case of maternal death in their state and look at all of this, the factors surrounding that death. And this statistic of 84% of deaths being preventable come from those detailed studies done by those state MMRCs. And preventable with timely medical care. So again, why are we thinking about Medicaid? Why are we thinking about health care? This is one of the reasons why, because we know that if we can get in there and provide timely, high quality care, that we could be preventing and averting maternal deaths. This graph shows you a little bit about the primary causes of death. And I show data from the 38 states that are included in this CDC analysis. And then I also it's always helpful to have local reference, show Illinois here in purple as a comparison. So the leading cause of pregnancy-related deaths nationally, if these 38 states are generally nationally representative, is mental health conditions and substance use disorder. And then followed by cardiovascular conditions and cardiomyopathy, which is heart muscle failure, hemorrhage, embolism, hypertension, and sepsis or infection. And then, Illinois maps on somewhat to that, although a higher proportion in Illinois are attributable to mental health and SUD. But again, I think this is helpful in thinking about the kind of interventions that would, actually make an impact to reduce maternal mortality. And then just another note about causes of death. These also vary according to when the death is occurring. So for example, sepsis or infection is a much more common cause right around delivery, where mental health and SUD are a much more common cause in the postpartum period. So speaking of timing, when are these deaths occurring? And it may be surprising to know that the majority of pregnancy-related deaths are actually happening in the postpartum year. And this is also something that was born out of the state MMRCs and deeper analyses of pregnancy-related death that have occurred in the last, 5 to 10 years. And this, it really represents a reconceptualization of the problem of maternal mortality and pregnancy-related deaths. Most people, when they think of, a maternal death, are thinking about something happening in the episode of care for delivery. But that risk continues through to the year postpartum. So 65% of pregnancy-related deaths are happening from, 1 day postpartum to a year postpartum. And this, really represents a new time period for clinical focus, for policy focus, for public health focus that, was just not considered really even recently. And this new conceptualization of the postpartum period has, been recognized by clinical bodies. It's being talked a lot about by policymakers and in the public health community as well. And just to say a little bit about how that's a transformation. So it used to sort of be that people thought of postpartum as just the 6 to 8 weeks following a delivery. And the care that was recommended for the postpartum period was really just a single postpartum visit, usually happening around that 6 to 8 week period. That's sort of what the clinical guidelines said. That's what people need. They just need that visit, 6 to 8 weeks afterwards. And this has really been reconceptualized as a result of the data that has come out of those state MMRCs. And now you'll hear this term, the fourth trimester, this idea that that postpartum period is just as critical as the other trimesters of pregnancy. It's also, while a trimester technically means a 3-month period, people are thinking about it as that extended full year after birth, reflecting the risks in maternal death that have been revealed. This period has, a new elevated importance. So in 2018, just an example of how this has been recognized, ACOG put out these new committee opinion on optimizing postpartum care, and they talk about, given the urgent need to reduce severe morbidity and mortality, the committee opinion has been revised to reinforce the importance of the fourth trimester and to propose a new paradigm of postpartum care. And what they really propose in there is, the 6 to 8 week visit is not enough, that single visit. There needs to be sort of a comprehensive model of care involving handoffs to other providers and follow up on pregnancy-related conditions or other conditions identified in pregnancy throughout that full year postpartum. And this is just a really expanded role for OB-GYNs to think about and a total rethinking of this period. Yep.
So when we measure maternal mortality, it includes the full year afterwards. So as you just showed us, that's when the majority of deaths are occurring.
Well, there's three, well, we can get into, do you want to get into the definition? So there's maternal mortality.
So it's maybe you want to hold off on this, but it's interesting that when you measure maternal mortality, it includes the full year postpartum, but in clinical practice, it's sort of 6 to 8 weeks and then you're done. So that disjuncture is already sort of confusing.
Yeah. So the maternal mortality rate includes pregnancy and 42 days after delivery. So that's the WHO definition of maternal mortality. And that's why I'm using two different terms, pregnancy-related death and maternal mortality. Those are different things. So there's maternal mortality is that WHO standard. That's the thing that all the countries are measuring. We have a direct comparison to other nations. And that's, the plot where I showed the different countries. Then there are two other definitions. One is pregnancy-associated deaths, which are all deaths during pregnancy and a year postpartum, regardless of whether they were related to pregnancy. So whether it was a pregnancy-related cause. Then pregnancy-related deaths are a subset of that, for which through MMRC review have been identified as being related or aggravated by a cause related to pregnancy. So they are different definitions. Other countries, as far as I know, aren't necessarily using the pregnancy-related death definition. We aren't comparing them. That statistic I showed is maternal mortality, which is comparable across nations. But yes, it's that these reconceptualizations follow a measurement reconceptualization that also occurred. Yeah. Yep.
The increase in the last 4 years.
That's maternal mortality rate, not pregnancy-related death.
Okay.
Yeah. Yes. So it's confusing. Yeah. So that one is the standard. And that's why if you ever see statistics, there are these three different measures that are used, the maternal mortality rate, pregnancy-associated deaths, and pregnancy-related deaths. Yes.
Does the pregnancy-related deaths, will we still see the exact same, with the graph look the same? Or maybe you're going to get to that.
No, and I'm not going to get to that, but yes, it would look similar. Yep. Yes. Thank you for that question. Yeah. I'm always like, do I get into that? It's kind of, yeah, but it's important and it's helpful, I think, for when you see these statistics to know that there are these different definitions and some of them are comparable to other countries and some of them aren't. And even speaking of, while we're on this measurement in terms of comparing, racial disparities across countries, a lot of other nations don't report maternal mortality rates by race ethnicity. And so they could be performing very poorly, but we don't have, the US is actually very good at reporting out health outcomes by race ethnicity, much more so than other countries. So I don't have a direct comparison to show you for that. All right. So we've been talking about maternal deaths, but I just want to take a second to think, beyond mortality. That's sort of what has gotten a lot of attention lately. There's this maternal health crisis, and it is reflected in the data shown, this rising maternal mortality rate. But I would argue, we should be focusing not only on mothers surviving, right, but on mothers thriving, right, and thinking more about well-being and supporting reproductive age women and pregnant people to, have the highest level of well-being that they can. Another point is that pregnancy is this really important opportunity where we can intervene to improve women's health in the long term. So people call pregnancy, a stress test, but it's this period of time where people are being brought into the healthcare system. Chronic diseases are maybe being identified that hadn't been identified before. It's this time of intense healthcare contact. Anyone who's been pregnant and has followed the prenatal care schedule knows that, right? It's very intense contact. But to actually capitalize on that requires postpartum follow-up. So thinking about that year postpartum as the opportunity that we have to translate those connections made in pregnancy through to long-term health care. Another point, thinking beyond mortality, is that poor postpartum health, especially poor mental health, maternal mental health, has really important intergenerational impacts on children that can generate and perpetuate health disparities across the life course, right? So that postpartum year is also the critical first year of a child's life. And we know that exposure to poor parental mental health in particular results in adverse health outcomes, poor cognitive, emotional development. And so it's also a critical period of intervention for children. And so I would say that thinking about improving maternal child well-being and reducing health disparities in that year after birth, we should be seeing this. It's not just about the maternal health crisis, but this is a major lever we have available to improve long-term just population health and health equity in the long term, right? It's really critical period. All right, so what are we going to do about this? So I'm going to talk a little bit more about this particular policy solution of extending Medicaid in the 4th trimester. And so maternal health has never gotten as much attention, I think, on the political stage as it has in recent years. It is part of initiatives and platforms at the state level. It's a major priority, has been for the Biden administration and for the vice president as well. So there is a lot of interest in doing something meaningful about this problem and on many levels of government, local government as well. And if you'll notice, if you look at a lot of these proposals, a lot of them talk about Medicaid, right? That is like the word that will come up a lot in these plans and in these platforms. Is a lot surrounds improvements and changes to the Medicaid program. And so I want to talk a little bit about why that is. Why is Medicaid a focus of these efforts to improve maternal health? So one of the big reasons is that Medicaid plays this really outsized role in covering pregnant people. So federal law requires states to provide Medicaid to low-income pregnant people under 138% of federal poverty, but many states do cover folks above that income level. So the median states covers pregnant beneficiaries up to 205%. And as a result of this requirement, Medicaid pays for almost half of all US births, right? So 42% of US births are covered by Medicaid. And it pays for even larger share of births among the people most affected by maternal mortality and morbidity, Black, Indigenous, and rural people. And another point is that a disproportionate share of the maternal mortality and morbidity that is occurring is among people with Medicaid at birth. So I took a look at the Maternal Mortality Review Committee report from Illinois, and they look at deaths by insurance status at birth. Not all states do that, but Illinois does. And they find that maternal mortality is 3.5 times higher for those who had Medicaid at birth versus commercial beneficiaries. So their rate, is 42 per 100,000 versus 12 per 100,000. So huge disparities by insurance status. So this means that if we could improve maternal health and rise up the outcomes for Medicaid beneficiaries, that has the potential to reduce disparities in maternal mortality and morbidity nationwide by race, by income, and geography. So it's this really, really important target for improving maternal health and health equity. But one of the challenges with pregnancy Medicaid and its design is that it's time limited. And this, kind of contrasts with what we were just talking about the majority of maternal deaths actually happening in that postpartum year, and this reconceptualization of that as a really important period for intervention. So that federally mandated coverage that I just spoke about only includes the period from conception through to 60 days postpartum. And that design reflects the program's original goal, which was to try to reduce infant mortality, which was the crisis of the day at the time. And it also reflects that old clinical postpartum paradigm of just the 6 to 8 weeks after birth as being part of the sort of perinatal period. And I just show, because sometimes it's interesting to look back at old documents to see how things are talked about, but this is a GAO report from 1989. But, they explicitly say, majority of states have expanded Medicaid programs for this population, which they meet the pregnant population. And they say the impetus for the legislation was congressional concern about the nation's high rate of infant mortality. They do not mention maternal health or maternal mortality in these documents. And then they talk about, extending coverage for 60 days after delivery. And then interestingly, this is where you get infants actually get coverage up to age 1. So this is, where that comes from. So any infant that's born to a mom who has Medicaid at the time of birth automatically gets that year of coverage. So we're just coming around now to thinking about, well, what about the other side of this dyad? What about that mom? Why does their coverage only end at 60 days after? And so what happens after those 60 days? And this is a graph from my, age-old dissertation, but this is showing actually pre-ACA data. So this is before the Affordable Care Act, before Medicaid expansion. And this graph, I think, is just really telling of, the program was doing exactly what it was sort of designed to do, or what you might expect it to do. You can see the lighter blue line here is uninsured, and the x-axis here is showing months before delivery, and then the white column is the month of the delivery, and then that goes the 6 months after. And you can see that people get picked up by Medicaid during their pregnancy. It peaks in that delivery month, and then they fall back off. And actually, the uninsurance rate gets almost back up to where it was prior to pregnancy. And this is pre-ACA, so uninsurance was high, right? It's like almost 25% in the reproductive age population. So, 55% of people with Medicaid paid birth were uninsured just 6 months postpartum. And, this is a low-income population in just that short period after birth. Since then, of course, we've had Medicaid expansion in nearly all states. We have some holdouts, but things have changed a lot since the ACA. And now what happens after 60 days really depends on the state you live in and whether you're in a Medicaid expansion or a Medicaid non-expansion state. So just like to show you, how does this eligibility work and how does this play out? So this is showing you that in all states, pregnant people are covered from conception through to 60 days postpartum at a median level of 205% of FPL. If you live in an ACA expansion state, they're covering low-income adults up to 138% of poverty, right? So if you're in those expansion states, you should be able to transition on to coverage as a low-income adult after 60 days. But there is this gap for folks between 138 and 205% of federal poverty, which is about $36,000 to $53,000 for a family of 3, in which they will no longer be eligible for Medicaid at all. If you live in a non-expansion state, that gap is considerably wider. So the median non-expansion state is covering low-income parents, up to 41% of FPL. That means that whole block from 41% FPL to 205% FPL is going to be in that gap of no longer being eligible for Medicaid. So those are people making as little as $11,000 for a family of 3 up to $53,000 falling in that gap of not, being eligible for Medicaid in their state. And I've done some work looking at, the impact Medicaid expansion had on improving perinatal insurance continuity. Just looking at those rules, it must, be better in expansion states than non-expansion states. But, we show that the ACA Medicaid expansion reduced, people losing their insurance around pregnancy by almost 30%. So it really made significant inroads in closing those gaps and providing a more continuous platform of coverage from preconception through to postpartum for low-income people. But a lot of uninsurance remains. So it did not completely solve the problem. So even after the ACA, almost 1 in 4 people with a Medicaid paid birth were uninsured by 4 months postpartum. So it's still a lot of low-income people. And then, of course, in these holdout non-expansion states, that number is much higher. So it's 37% of people who had Medicaid at the time of their birth are uninsured just 4 months after that birth in Medicaid non-expansion states. And if we look at state disparities in the post-ACA world in postpartum uninsurance among Medicaid paid births, there's a lot of variation, which just map onto the Medicaid eligibility rules and expansion status. So in Illinois, this is data from 2015 to 2018, about 17% were uninsured after a Medicaid paid birth, but in Texas, it's nearly 60% are uninsured. And that's because you have to make as little as $4,000 for a family of 3 to be able to qualify for Medicaid after 60 days in Texas. So very high levels of uninsurance in some of these states that have very restricted Medicaid eligibility levels. And this time-limited duration of pregnancy Medicaid and the fact that Medicaid is disproportionately enrolling people of color creates these really wide racial and ethnic disparities in perinatal insurance. So if you look at white non-Hispanic people, 75% have a continuous source of perinatal coverage from preconception through to 4 months postpartum, compared to about half for Black, non-Hispanic, Hispanic, and Indigenous people. This design of Medicaid and the fact that it's disproportionately enrolling people of color is just contributing to this structural barrier to access to care in both the preconception and also the postpartum period. All right, and so to add a sort of human element to this, I don't know if anyone here followed the Lost Mothers project. So this was a really amazing journalism project run by ProPublica, led by Nina Martin and Julia Belluz. And they told many, many stories of lost mothers across the United States, and really added some human contours to these statistics that we are all seeing. I'm just going to share one story that they wrote about that's related to uninsurance in the postpartum period and the implications that it had for one mom. So a few weeks after delivering her 4th child, Brittany Henry, a 28-year-old Houston resident, suffered a heart attack, a complication associated with pregnancy. Henry went home from the hospital with a stent in her left coronary artery and a fistful of prescriptions, all paid for by pregnancy Medicaid. But after 2 months, those benefits lapsed, and her family was left scrambling to get her the medications she needed. When she was about 5 months postpartum, Henry begged a neighbor to drive her to the emergency room, and she collapsed on the sidewalk and died. If not for her insurance struggles, her husband, Raphael Martin, asserts, the outcome might have been different. She'd still be alive. And this it's every single maternal death that happens is a tragedy. It's a tragedy for losing, a young person with so much potential for their family, for their child, for society. And so I just really, this is a beautiful project and adding, the stories of this crisis really to the conversation. So how can we solve this? And some of this journalism, oops, what am I doing? This is going forward. It has really accelerated, I think, policy interest in this period. And one particular proposal has sort of risen to the top. And this is to solve this problem through a very simple solution, which is just, why don't we just extend Medicaid eligibility from 60 days to 1 year postpartum? It's easy, right? So people are losing coverage 60 days after. It's a critical period. There's still really high health risks, as seen in that story. Why not just extend that coverage to 1 year? And this policy proposal was solidified in the 2021 American Rescue Plan Act. That gave states the option to adopt this extension. So states could extend their Medicaid with federal matching dollars, so they'd get the standard matching dollars that they get for their Medicaid program, to simply extend pregnancy Medicaid a little bit longer. And originally it was only supposed to be 5 years of funding because it was under this sort of COVID relief package, but it's since been made permanent. And one thing just to note about this, and it'll be relevant soon when I talk about coverage, is that like pregnancy Medicaid coverage, it excludes recent and undocumented immigrants, right? So there are rules that the federal government has around covering, using Medicaid to cover immigrants, and there are certain mechanisms states can use to do so. But this extension is also subject to those same, usual constraints around the coverage for immigrants. This proposal, for anyone who studies or knows anything about the Medicaid program, it's actually remarkable how it has been adopted so quickly across the country. You know, red states, blue states, all of them except Wisconsin and Arkansas to, you know, have adopted this policy within a period of a couple years. And there's only, you know, what Wisconsin is definitely, I think they're going to be moving on it soon. It's through the Senate. I think it's probably going to make it through. So really, it's only Arkansas that remains. And so, you know, this is kind of going to be seen as a national policy. And just, you know, in Arkansas, the story is that, you know, the governor is very much against expanding postpartum Medicaid coverage. It's sort of interesting because she's you know, a mother herself, but you know, is one of the most staunch opposers of this policy in the country. But it may be that eventually there's enough pressure, given how many states have done this, that Arkansas also follows the rest of the states. All right, so this is happening at a remarkable pace across the country. Will it work to improve coverage? And I'm going to talk a little bit about what we can learn about what happened during the COVID public health emergency, and how that relates to, whoops, sorry, I keep pressing the wrong one. Improvements in coverage that could be expected under these state extensions. Yep.
What were Idaho and Iowa? Why were they green? I couldn't see that.
Oh, they're just, they've gone through, so it hasn't been implemented yet, but it's through the legislature. Yeah. So I think they may just be waiting on CMS approval, right? Because they're all of these state plan amendments have to be approved by CMS. But they're Navy. They're effectively done. Yep. All right. Okay, so CMS started to approve these state postpartum Medicaid extensions in 2022. Actually, Illinois was the first state to do this, so kudos to Illinois for leading the whole pack. But however, you know, these extensions were like effectively moot because of the maintenance of effort provision under the Families First Coronavirus Response Act. So during the public health emergency, states couldn't disenroll anybody from Medicaid, including, you know, people at 60 days postpartum. So we had this situation where everyone had sort of continuous Medicaid coverage. So you could think of this almost like a national de facto postpartum extension that was happening during that public health emergency. So the question is there anything, you know, we can learn from that? So we've done a little bit of work trying to look at this, and I'm not going to, you know, go into the methods here. It's more going to be on the highlights of the findings. But one thing that, you know, we can do is look at the impact that this policy had based on differences in the pre-existing Medicaid eligibility rules across states. So this is a national policy. No states could disenroll anyone from Medicaid, but the impact the policy has depends a lot on how big is that gap between pregnancy Medicaid and Medicaid for parents and adults in a given state, right? If they're really similar, then the coverage gain isn't that much, right? They're already covering low-income adults or people after 60 days up to pregnancy Medicaid levels. But if the gap is big, that represents a very large increase in postpartum coverage. So there's this interesting state variation in the policy that we can use or exploit to try to look at what's the impact of increasing the eligibility level postpartum. So just an example to compare like two similar states and how they had different kind of exposure to this policy. In Montana, the pregnancy eligibility threshold is 162% FPL. For adults, it's 138. So the gain there is only about 24% FPL. The additional sort of cover income levels that you're covering postpartum only is, you know, the 24% percentage points different. But in Colorado, the gap there is between 138% and 265% of federal poverty. So it's a much larger gain in eligibility postpartum. And when we look at this, and we do this in sort of a continuous difference in differences framework, but the highlight is that, you know, we find that self-reported postpartum uninsurance, this is based on survey data a few months after birth, is reduced by almost half during the COVID PHE. So a really, really significant reduction in people going uninsured after a Medicaid paid birth. And 100% FPL gain, we use that because that's a median increase across the states. So it looks like, coverage really, really does go down a lot. It isn't eliminated, but it's about a 40% reduction in self-reported postpartum uninsurance. And one thing I want to point out, if you look at this by race ethnicity, it looks similar for white and Black respondents to this survey, but we don't find a significant difference for Hispanic identifying birthing people. And even during the PHE, about 30% of Hispanic people with a Medicaid paid birth were still uninsured 4 months postpartum. And I just want to mention here, and not that Hispanic ethnicity is obviously not a perfect proxy for immigration status, but there are higher levels of immigrants among the Hispanic population. And there is a program called Emergency Medicaid that even though if you don't qualify for Medicaid in your state because of your immigration status, you're still going to get emergency Medicaid that's going to cover the cost of your delivery hospitalization. So you'd still have a Medicaid paid birth, but you may not be eligible for Medicaid outside of that, right? You wouldn't be eligible during your prenatal care or postpartum. And they also weren't, subject to the continuous eligibility rules. So I think that's what we're seeing here is that, there's a greater representation of emergency Medicaid here where they're not getting access to this continuous Medicaid eligibility afterwards. And this is a study by another group, not our group, but it's just looking at, instead of survey data that we looked at, actually using the Medicaid enrollment data from, from CMS. And they find a similar decrease, so about 77% decrease in Medicaid disenrollment. And so you can see these are months postpartum. This is a cool graph that they made. This is by Sarah Gordon and Ben Summers and their team at ASPE. And they show that prior to the pandemic, that's the golden line. You can see this is disenrollment, like how all this disenrollment that happens at the 3-month mark after pregnancy, after delivery, I mean. And then during COVID, whoop, sorry, I didn't know that was touchscreen. Or maybe I touched this. How that just smooths out, right? That disenrollment just like goes away, and it's like a flat line where no one is getting disenrolled after that. But they also find the same thing that we do, and that they find Latinos had a significant decline in disenrollment, but they had still at this high rate of losing Medicaid during the public health emergency. So still about 20% were disenrolling from Medicaid after birth, compared to 6% among white non-Latinos. So this sort of story suggests that first order goal of improving coverage is likely to be achieved, now that we have these sort of state extensions nationally. But there's a couple, I think, important lessons from these studies that we've done during the PHE. One is that inclusion of non-qualified immigrants is likely going to be critical to the overall impact on rates of postpartum uninsurance and inequities. So most of the residual postpartum uninsurance that will remain is going to be uninsurance among undocumented and recent immigrants. Those are the populations left out of this policy. States have discretion on whether they can include non-qualified immigrants in these extensions. They have to use their own money, or they can use some money from CHIP, called the Health Service Initiative Funds. But many states are unlikely to do this, because already they have the option to do this for pregnancy, but only, depends on the rule you're looking at, but about 20 to 30, states include immigrants and recent immigrants and undocumented immigrants in their pregnancy Medicaid. So this is just a big state decision piece that will matter. The other thing that I think this data shows is that beneficiary awareness will be important. So if you compare our studies, one that looked at survey data, that's self-reported insurance, the other looked at the Medicaid enrollment data, showing that there's a lot higher rates of postpartum Medicaid enrollment in the administrative data than we see in the survey data. And this might be just something about the PHE because people didn't know about continuous coverage. But it does tell us that, coverage can only be effective if people know that they're covered. So making sure, and people do have, particularly if they had a previous pregnancy with Medicaid, they're going to have it in their mind that their coverage ends 60 days. You get a notice from the state that comes in a letter that says your coverage is going to be terminated. If you've received that letter in the past, you might assume that it will continue to be the case if you have another Medicaid covered birth. So this is going to be really, critical to make sure that beneficiaries are aware of this coverage, they're aware of how long it lasts, and when that next cliff comes at 12 months, which is going to still be there, we're just kicking the can down the road a little, that they're prepared to make a transition to another type of coverage. So we also aren't, resulting in uninsurance at 1 year instead of 60 days.